panelists and my colleagues who are here to attend the webinar today. I am Dr. Sagar Nambiar, Resident Surgical Gastroenterology at SK Hospital, Trivandrum. At the outset, I'd like to thank my dear teacher, Dr. SENADHIPAN sir, for giving me this opportunity to be a part of this prestigious and one of the most popular learning forums in surgical gastroenterology, the SENADHIPAN Education Foundation. And I consider myself very lucky to be learning all the tricks of the trade from Baiju sir. Without further ado, I'd like to welcome our presenter and moderator for today's session, Professor VIKRAM sir and Dr. KALAYARASAN sir. No discussion on the need for publications would be complete in this era of evidence-based medicine without the mention of Professor VIKRAM sir. Sir currently holds the position of the Academic Dean and Professor of General and GI Surgery at JIPMER, Pondicherry. He has an experience of over 30 years of teaching and clinical practice at JIPMER. An avid publisher that he is, Sir has published over 200 plus papers in peer-reviewed journals, 55 chapters in books, editor of multiple surgical journals. Sir's exemplary leadership skills have seen him hold several positions of significance, some of which include being the past national president of the Indian Association of Surgical Gastroenterology, the inaugural president, Indian chapter, Society for Surgery of the Alimentary Tract, USA, member of the research committee, the SSAT, member of the Surgical Specialty Board in General Surgery, and Royal College of Surgeons of Edinburgh. Professor VIKRAM sir is a dynamic orator and an eloquent speaker, and has given more than 10 prestigious orations, including Professor N. Rangabhashyam oration, Dr. S.K. Bansali oration, the MRC oration. He's received the Distinguished DNB Teacher of Excellence Award in 2018 and the Great Contributor Award from the MRC 2021. Sir is also the Editor-in-Chief of the Indian Journal of Surgery, Journal of Minimal Access Surgery and the Allied Sciences, International Journal of Advanced Medical and Health Research. His research contributions stand tall, and some of which include contributions in the field of H. pylori and duodenal ulcer, corrosive gastric strictures, ERAS in emergency surgery. And Sir's specific areas of interest include upper GI surgery, H. pylori, corrosive injuries, and minimally invasive GI surgeries. From that, I'd now like to welcome a moderator for today's session, Dr. KALAYARASAN sir, a doyen in the surgical fraternity, admired for excellence, mentorship, and innovation, and a true inspiration for every aspiring surgeon over here. Sir completed his MBBS from JIPMER and went on to attain his Master's in General Surgery from the same college. Sir completed his super specialty degree in MCH from the G.B. Pant Institute of Medical Research, Delhi. Sir currently holds the position of the Additional Professor in the Department of Surgical Gastroenterology, JIPMER, Pondicherry. Some of the other positions that he's held over the period of years include the Executive Committee member of the ISG, member of the Steering Committee, Asia Pacific Advanced Network, Associate Editor of the Indian Journal of Surgery, Associate Editor of the International Journal of Advanced Medical and Health Research. He's also the editorial board member of the World Journal of the Gastrointestinal Surgery. A few additional feathers to his cap include the FRCS degree from Edinburgh, a fellowship in liver and transplant surgery, Surgical Society of the Alimentary Tract, and a member of the IASG. A colleague of mine on the same forum did mention about Sir's impeccable track record as a publisher, and I'd like to reiterate that with Sir having written books and chapters, he seeks to keep spreading his knowledge through the research publications, and Sir has published books and chapters in over 18 textbooks. He's a reviewer of more than 15 PubMed index journals, with over 166 publications to his credit and over 1,800 citations. His keen interests are on liver and colorectal surgery, where he leaps to improve surgical outcomes through innovative, minimally invasive surgery. With that, I'd like to welcome both of you esteemed professors, and we would be greatly honored, sir, if you could lead the session and share your expertise with our audience. Thank you, sir.
Thank you, Dr. Sagar. Mic is over to Dr. KALAYARASAN.
Thank you, sir. I'd also like to thank Professor SENADHIPAN for the kind invitation and Dr. Sagar for the introduction. It's an honor to moderate today's session because the speaker is actually my teacher, and he's the one who has taught me the basics of surgery and also the ABC of research. So, I mean, all my the surgical expertise and the experience in research I owe to Professor Vikram Kate sir. And so I'm really honored to be moderating today's session. And with pleasure, I request Professor Vikram Kate sir to deliver his lecture.
Thank you, Dr. Kalay. Vikram sir.
Is it visible?
Yes.
Am I audible clearly? Is it
Yeah.
clear? Yeah. Good evening to everybody who have assembled here to have some discussion on this important topic on publications and research. And I would like to first thank Dr. Baiju for inviting me for this prestigious webinar, and Dr. Nambiar for the kind words about the CV, and my student and Professor Kalayarasan, who, as has been already told, who is not only very well known in India, but equally well known internationally. I bring you greetings from JIPMER, Jawaharlal Institute of Postgraduate Medical Education and Research, situated at Pondicherry. And I'm very grateful again to the president of the SENADHIPAN Education Foundation, Dr. Baiju SENADHIPAN, the senior consultant head of department of GI-HPB Pediatric and Transplant Services at Trivandrum, for this invitation to this lead talk at this SFS webinar series. And when I was looking at people who have delivered the talk, indeed, definitely it's the who's and who in the world. Now, this will be the components of my talk. Publishing and research, is it necessary? A little bit I'll touch, because naturally I'm going to speak in favor of that. Overall benefits of research, there are certain myths around this publications and research. Publications and professional recognition, how research and publication generate evidence, and role of research in policy development, and its role in global leadership and academic growth. So this is the pathway I'm going to follow in this talk of roughly about half an hour. Now, is research and publishing necessary? If you look at the policy makers all across the world, not only in our country, they heavily actually in favor of people who prioritize research. All the academic award system actually favors these people who are oriented towards research. And research experience is still the most sought after attribute among senior academic scientists and clinicians. So is it only necessary if you are in an academic setup? No. Anyone not directly in academics too benefits from research, because they will know about the updated latest developments, and they'll also learn about research and publications. If you have not published a paper, if you're not familiar with research, it may be very difficult to understand when you read a scientific research paper, interpret, and then benefit from reading and interpreting research. The other advantages, that was the previous slide, showed a little bit of personal gains of research, but overall research actually helps to the fraternity of medicine, advancement of medical knowledge. As we know, medicine evolves rapidly, and it is the basis of this rapid evolvement is research, because it leads to new therapies and surgical techniques. Once you have developed these and you apply it to the patients, the outcomes will become better in clinical practice. And if the person who is a good researcher, a clinician researcher, what we call it as a clinical scientist, while treating the patients during patient care, the person can easily identify the gaps in patient care and address them very scientifically to bridge the gaps. So if you want to propagate your research, if you want to do any work, any research, there are two major components of writing your papers and then publishing in a scientific journal. So little bit I'll share about our experience which I gained in my initial period of my faculty's job at JIPMER. We started working for my doctoral work on Helicobacter pylori in 1995. We faced lots of challenges. It was my mentor, Professor Anand Krishnan, who encouraged me for doing this doctoral work. But what were the problems? This was a very novel area. Even though H. pylori was discovered roughly more than 10 years or 12 years earlier than we started, but still practically nothing was known in India. The bacterium, the nomenclature, still people were calling it like Campylobacter pylori and not Helicobacter pylori. Diagnosis, nobody knew. There were no facilities available, any tests available. And over a period of time, just there was introduction of this ELISA kits for IgG antibodies. Only antibody testing was little bit known when we started the work. But this was in 94. Over a period of time, the PhD time is around 5-6 years. We started working on each aspect of Helicobacter pylori. One of the complications, you can see that publication, overall the role of H. pylori in upper GI tract disorders in patients with duodenal ulcer with gastric outlet obstruction. This was very common when I joined JIPMER 35 years back. Practically every day we used to do an elective surgery for this. Then after doing the surgery, we wanted to know what happened to H. pylori after tracheotomy and drainage, its relation to gastric carcinoma, which is very common in the south, erosive gastritis, other disorders. Then once you have diagnosed H. pylori, how to treat it, the different therapies, regimes that were used, its role in ITP, its role in patients with cirrhosis and portal hypertension. So all these areas over a period of time, last 15-20 years, slowly we developed on that. And then we found out many aspects of H. pylori, and we collaborated with people as well as, of course, when you do research, it is not your own research you look back. It is the research done across the world that you look over it. Now, if you look at this paper, this paper was published in 2000 Annals of Surgery. This is basically a landmark paper, what we call it as a seminal paper. And why it is a seminal paper? It changed practice. Now, during this time, the role of H. pylori in upper GI disorders was reasonably established. But in complications of duodenal ulcer, it was not well established. Bleeding it was to some extent, but not in perforation. So earlier, as we know, nowadays perforations are still there in India. What we used to do is that if a patient has got an ulcer perforation, either we do a mental patch or we do a definitive surgery. The definitive surgery in emergency carries a risk. So whether this should be carried out or not. So this paper was based on that if you eradicate H. pylori, if it is present post-surgery after just an omental patch, you do not have to do further surgery in that patient. So this was the first paper published in world literature, which said, although it was published in 2000, this concept to get established took 10 more years. And immediately 1 year later, we published in British Surgery, a little larger number of patients, a similar type of thing. And as I said, now 2010 to 15, some meta-analysis have started coming over. And this is a standard of care now, that you don't have to do a definitive surgery for peptic ulcer perforation. So this paper naturally received it was received very well. It was listed in the landmark papers from UK book and also in the top 100 papers. Just to emphasize that if you do something very novel, it might not be possible and feasible in the early phase of your research career, but definitely then it can get a very wide visibility. Based on our publications on lots of publications on different regimes. We're also invited to write a systematic review. A very prestigious journal has got an impact factor of 8 or 9 right now, drugs regarding 2 therapy regimes. One of them we had actually published. And Dr. Kalayarasan, who's moderating, he's also the principal person who actually wrote it with us. So why we did this, why I thought about this particular topic for my doctoral work. This was based on this publication. Now, this publication is a letter to editor published in Lancet by 2 people, Barry Marshall and Robin Warren. Robin Warren was a senior pathologist. Barry Marshall was a registrar in medicine. He was a trainee in medicine and he thought that in the stomach, some bacteria can survive. People had the idea at that point of time that stomach has so much of acid, no bacteria can survive. He proved it. They published it as unidentified curve bacillus in the stomach of patients. Perseverance was there. They made sure that they did follow up the way we did lots of papers on H. pylori. They followed up. And this is what the reward they got 25 years later. They awarded Nobel Prize for changing the paradigm shift of the treatment of peptic ulcer disease. So look at this now. If that letter to editor was not published, or that letter to editor, these people would not have sent. It might have taken many more years or decades to understand the pathogenesis of peptic ulcer. And we'd be treating it continuously like a disorder which comes and goes, and you cannot eradicate this disease. But nowadays, as I said, when I joined JIPMER, we used to do 150 elective surgeries for peptic ulcer disease every year. Now we don't even do 5. So over a period of time, 20-25 years, see how the concept changes of treatment. You cannot say that the tradition says like this, so I will do that surgery only. So it's the research only which changes. So coming to the topic for today, publish or perish, from where it has come. Because if you have done research and if you have not published it, you may as well consider that the research is not done. Unless and until you publish, unless and until it's peer reviewed, unless and until it is seen by external peer reviewers and it gets published, it is no longer considered valid. And how many people in how many conferences you will tell about some of your findings which are found on research. That is what is the importance of publication. The other important factors that come with publication is research cultivates a culture of evidence-based practice. I'm trying to emphasize that if a person is immersed in research while they're doing their clinical practice or non-clinical paraclinical practice, in those circumstances, if you're not immersed in research, what will happen is you follow your tradition. In my personal experience, so many times I hear this statement in a conference. I have not had this, I will practice that only which I practiced 20 years ago. And I feel that that is the best possible treatment for the patient in those circumstances. But that's entirely not correct, because unless and until you follow the evidence, earlier we used to do open surgery, then we shifted to laparoscopic surgery, and now we are shifting to robotic surgery. So from where that has come? It has come from research. So that is why this strengthens clinical guidelines and reduces variability in practice. Variability in practice has to be contained, because if everybody does the same, that is what means that everybody is practicing evidence-based medicine. This also leads to better diagnostic approaches, treatment protocols, and preventive strategies. Once you have good knowledge about the current practices of patient care, you will use that in your diagnosis, treatment, and then naturally the latest methods you will try to prevent the disorders. And the students also, if they're immersed in research, they will actually learn the pathways grounded in evidence rather than tradition. Because there's no point when some of the lectures I've given on ERAS. So their first line, Henrik Kahle said, who actually started the principle of ERAS in the world, why the patient is still in the hospital, why the patient is still on a nasogastric tube, why the patient is still on a catheter. All these things were traditional. Nobody will remove a Ray's tube or a catheter if you do major GI surgery for a long period of time. Patient will stay for days in the hospital. So all those things have to change. Once you have got a good grip on research and a focused area of research, then comes the next step that you start fostering innovations in them. innovative surgical techniques, because you have become the master of the standard of care and you'd like to move forward from what is existing and what can be better. So again, an example from a mentor, Professor Anthkrishnan, whose area of interest is corrosive strictures of upper GI tract. And you can see there, this publication, 30 years collection of data. And from that, you have pearls coming out for the management, classification of strictures, how to manage them. If you have difficulties, management protocols, algorithmic approach, and further research. All this has come from the collection of data, understanding the subject, understanding the disease, and then publishing at different stages and phases throughout the life. You can see here, this is a very difficult type of problem to manage. Similar type of thing. Collection of the data, going back and seeing actually what you have done, what can be changed, what can be better. All those things, unless and until you disseminate to others, it will go down with the same people who are there, and over a period of time, everybody will forget. So whatever they have done, the plus points will get negated if it is not published. Because as I said, how many times you'll go and give a lecture in the conference, there is a limit to it. But if you publish something 50 years later, 100 years later, 200 years later, also somebody can read about it. This is a BMJ Open one paper, a 3-stage review where they've done the engagement of clinicians and organization research. Does it improve health performance? And you can see there, out of 33 papers, 28 of them identified improvements in health research performance. So not naturally, all these things document very well that unless and until, it's not a question of doing clinical practice. Everybody does sincerely, everybody hopes for the best of the patient. But unless and until these things are imbibed in it, without imbibing that, it is very difficult to move forward and have the correct possible practice for the patients. Now, there are certain myths around research. One is that people feel that we should only read the journals. Why we should write into it? Because that is supposed to be written by people who are working in institutional settings. Research is not a ball game. They should do it, they should publish, they should find out, we'll read it, and then we will apply it on our patients. That is very much incorrect. That's a myth. Ethics and other committee support is required. This I cannot get it. I have got a good practice, but in my circumstances, my setup, it is not possible. From where will I get the funds? Even if I get the funds, again and again, I cannot get the funds for doing the research. And if I don't find what I want to find, negative studies, nobody will publish this. So whole exercise will go down the drain. But these are all myths. And look at these papers. Look at the types of original articles. Retrospective case series, what you saw on the corrosive, it comes into this category. Cohort studies, case control studies, none of them require any type of institutional setup. Although we had published it from an institute, but definitely anybody who records the data on a prospective basis, what we usually call a retrospective analysis of a prospective database, you can write all these papers. Surgical techniques and innovations, as everybody knows, you can certainly do it at your level. Case reports and images definitely do not need. And once you have mastered on something, once you have publications something, you will be invited by journals to write reviews, systematic reviews, meta-analysis, the way we got an invite for all these things. So you can propagate research forward. Institutional setup is also not required for, as I said, ethics committee or some other committees. Okay, you have regional committees. Of course, you have to get it cleared in ethics committee. In India, you have to do the registration under CTRI when you do especially randomized controlled international trials, clinical trials registry of India. So all those things require ethics certificate. But you have regional ethics committee, you have to find it out. Find out from people who are in a similar setup like you, and then get those clearances and then go forward with your research. So this is again, as I said, just to give you an example, all this is another paper. Again, over 30 years, the data was collected, it was analyzed, then we had further innovations on that, and over a period of time, these papers have come out of it. Regarding funding, Now, these 3 papers, if you look at them, all of them were accepted in plenary presentation in Digestive Disease Week conference in the US. It's one of the largest conferences of GI in the world. 2 of them, the first and the third, were included in presidential plenary. That means the outstanding papers only are included in that. And they are on ERAS. You can see practically everything is on ERAS, randomized controlled trials. And none of them required any funding. Usually funding means, what I mean is like you have to get some kits. You require something money for doing the research. This is absolute clinical research. This is absolute standard of care what you do. And when you compare it with the interventional arm and the comparative arm, technically you do not require any funding to do this sort of research. So without funding, you can bring out very good papers. Something about negative studies. If you do not get a result which you're expecting, there is a tendency that you put that file of that project into the drawer. What we call it as a file drawer problem. But this should not be done. Why it should not be done? First reason is you are creating a publication bias. If a meta-analysis is done, they'll put a funnel plot. And you'll find out that treatment works, treatment doesn't work. Why this is blank? Because people who thought it is a negative study, they have put all their projects in the drawer and not published it. So that should not be done. That should not be done. You publish positive results, publish negative results. Everything adds to the literature. And when you do a publication bias, and if there is no bias and you find the effect is useful, definitely this sort of symmetrical normal distribution meta-analysis will give a more appropriate result than this sort of asymmetrical publication bias. Again, few of our examples you can see here. Now, this study, we did a randomized control trial in elective colorectal surgery, gave high preoperative oxygen to find out whether it reduces infection. It did not, absolutely did not. Again, it got included in a plenary presentation and got published in JOGS, that is the Journal of Gastrointestinal Surgery, which is the official journal of the USA GI Surgery Association. You see this again, no correlation between H. pylori and pancreatic cancer or periampullary cancer. Still, it has got published in a PubMed Index International Journal, Journal of Gastroenterology. So, what I am trying to again emphasize is that from our own experience, that whether it's a positive study or whether it is a negative study, go ahead with publication. This is just to showing directly our examples at our level. If we can publish, why you cannot publish? Little bit about levels of evidence. Where do we start if I want to do research? Some of my younger colleagues would be there, students would be there, trainees would be there. So where do I start? Directly, shall I start with a meta-analysis? Directly, shall I start with a randomized control trial systematic review? So sometimes they are in a dilemma like that. Mountain of evidence. Is climbing to the top necessary? Climbing to the top in the initial phase, definitely not necessary. Once you become a good mountaineer, then only you should reach the Everest. That's a general rule. The same thing you actually follow here. So this is what we usually advise, that in the initial phase, when you are starting to write, you are not that familiar with this process of writing. Start with case reports or small case series. It's not at all difficult to start with that. Then go over a little bit to analytical studies, case control, cohort, cross-section. Once you have mastered that, then you can slowly move on to randomized controlled trials. And then meta-analysis, of course, they are usually by invitation. So this is randomized controlled trial, generates level 1 evidence. So over a period of time, we had written many other papers, but in the last 10 years, now we have shifted mostly to RCTs. The advantage of RCT that it generates level 1 evidence, high level of evidence, and the preference in journals and the acceptance rates is in general high if you follow a proper authorized, what you call it as consort sort of a writing method for this randomized controlled trials. So you can see most of them are investigator-initiated randomized controlled trial. That means not sponsored, not dependent on multi-centric support. So it is a single center randomized controlled trial. These are all RCTs. And you can see a little bit focused on an area. This is on pancreatitis. This is again on pancreatitis. again on pancreatitis, and then we have done some on ERAS. You can see all this ERAS what I've shown you, especially emergency ERAS. Emergency ERAS, very few articles were done, even though ERAS started, it was initiated in late 90s. It took almost 20 years for the emergency ERAS publications to come in because people were very apprehensive how to work that ERAS protocol in an emergency setting. So this is the reason why RCTs I've already mentioned, because they have least biased, so they are considered gold standard, a good RCT, of course. So why there is an apathy towards research? A lack of faith in research findings. Most of them will say, no, what I do traditionally, that's good. What some publications and all they are saying A is better than B, I don't believe that. So that leads to poor interest in research, resulting into low quality of research or vice versa. But remember, this is bidirectional. If you have a good faith in research findings, you will do good research and the production of the values, the outcomes are good. Naturally, your faith will improvise. So this is how it is. So that is why that apathy towards research should not be there. And you should have always a positive attitude towards it. Doesn't mean that every article which is published is good, but you can be selective. So what are the issues related to apathy towards research? Most specialty or subspecialty courses don't have a proper defined curriculum about research methodology. They think they would have learned it in the graduation stage. Little bit they learn. During the dissertation stage, again, little bit only they learn, especially if the mentor is good. And the mentor is not good, then they just complete it as a ritual. So nowadays, what has happened is societies. We can see here an example. SENADHIPAN Education Foundation, Dr. Baiju's society, they have taken over this job of disseminating knowledge. So it's a very, very excellent motive. Similarly, editors of journals, scientific societies, they are starting to have this medical research and scientific writing programs in that. We recently did one for Masikon, we did last time for Asikon at Agra, and some more over a period of time in different states we have done. And it's a small group discussion, hands-on training. So what I would like to emphasize, this is the latest one, what we have done at Jaipur and Amasikon. This is what I would like to emphasize. Look at this, forget about me. All four of them, including Dr. Kalayarasan's moderating, all these are my students. They are not at JIPMER right now. Like two only are there at JIPMER. They are different specialties. They are not surgeons. She is a dermatologist. She is a neonatologist. But what I'm proud to say that it is like a baton we have passed on to them. And it is a matter of time, I will not be there. And one of them will be the course director for this sort of program. And they will propagate research in the society. So this is what we feel happy about it. It is not that what we do, but what others do. When I'm looking at Dr. Nambiar mentioning about Kalayarasan's CV, and I'm looking at his publication achievements, and he's at least more than 15 years younger than me. I'm very certain he'll be at least 4 times or 5 times better than me when he reaches my age. Building critical thinking in mentees. That is what I mentioned just now in my previous slide. That is what we have bought in our students, and today they are faculty for research. They are excellent clinicians, but side by side, more important than that, they are also excellent clinician scientist. This is Dr. Kalayarasan's paper. You can see that when he did during his training period, it was translational research under the guidance of Professor Anand. Estrogen and progesterone receptors in esophageal carcinoma. It is not at all typical clinical research. It is a translational research. Another one of his colleagues is a little senior, 1 year senior to you, senior to Dr. Kalay. He's also a GI surgeon in Hyderabad. Again, you can see this translational research. So when you imbibe these sort of things into the students at an early phase, no doubt it will be that the son will cross the father and the student will cross the teacher. So continued focus research also lead. That's why I said it's always better initially you do a wide level research, then go on to a focus research. Invitation to participate in policy development consensus guideline. This is the first extensive consensus guidelines on H. pylori infection published from India. And you can see that this is published in 2021, almost you can say 40 years literally after the discovery of this organism. Initially, 1 or 2 guidelines were there. All of them are medical gastroenterologists apart from me, but we have done extensive work on that. So you get invites to this sort of this sort of forums and this sort of scientific meetings, especially the consensus guideline. And there's a consensus guidelines which is again been published in Indian Journal of Gastroenterology on corrosive strictures. So what does it lead? People say, what I will get from it? Why I should do research? I am doing my clinical practice. I am very happy within that. So when you have research publications, you gain visibility among the peers, nationally and internationally. This recognition opens opportunities for collaboration and grants. It's not for you. You may become very famous, but you have to make sure that this percolates to your students. Once it percolates to your students, as I said, it's a matter of time. They will reach your height, your stature, way ahead of time, and they will cross you. It also raises the academic profile of the department, of the institution, and also of the country in an international forum. So you can see that this is one of abstracts which we had presented, and it was listed as the 6th best abstract in the World Society of ERAS Congress. So you get opportunities to meet. During that Congress itself, I could meet Hendrik Kele. He is the person who started the concept of ERAS first time in the world, and recently he was awarded the Nobel Prize in Surgery, which is £100,000 by the British Journal of Surgery. It's considered like a Nobel Prize, £100,000. It comes literally a crore of rupees. So that is what he was awarded very recently for his pioneering work. And then last month I met Dr. Lindqvist. He is also another pioneering, he has done extensive work and is a co-founder of ERAS Society. All these opportunities come if you get imbibed and immersed in papers, research, and then you meet them. And of course, you can see this. This was the cherry on the top when I presented in the digestive this week. The man who came and was discussing about my paper was no other person than who discovered Helicobacter pylori in the world, Nobel laureate Barry Marshall. Then you, of course, get the citations, such index. These are indices of research, and over a period of time, and these keep on increasing. And then you also get invites to the different societies nationally and internationally on research and other things. This is a research committee of the Society for Surgery of the Society for Surgery of the Alimentary Tract, SSIT, what we call from the US. Global competitiveness and leadership. Again, as I said, it is institute-based, state-based, region-based. Nations with strong clinician research base lead global health innovation naturally. Unless and until you have a backing of a strong clinician research base, you cannot go ahead in research or innovation. It is extremely important that everybody should contribute to research, because you are consumers of research, you are consumers of knowledge produced by research. So how can you say that I only eat about it, I'll only eat that and I'll not contribute? One day everything will get over and then you'll look for it, where should I get it, because you have not contributed. Everybody thinks like that, others will contribute and I will only utilize it for my purpose. That is really wrong. So that's why these sort of things are very necessary. You can see here one of the presentations. This is during the COVID time. So we had what do you call that time all were online presentations only. So we had I am happy to say that our institute was listed with the top centers in the world. This is Cleveland Clinic and it is Mayo Clinic, Rochester. As you know, Mayo Clinic is always labeled as top center in the world consecutively for so many years. And then, of course, last year, this presentation, we had, as I said, the outstanding papers, they go into the presidential plenary. And I'm happy to say that this out of 5-6 papers, we were there in that. And the person who's chairing is the president of the SSAT for that year. So all this just to emphasize that you have to start early, start whatever level you can start, you start. And then it takes you to many heights. Research output enhances the reputation of hospitals, as I mentioned earlier, and also attracts fundings, collaborations, and the best students. This I can say that because I am working in an institute which is ranked consistently within top 5 for the last so many years in our country. And you can see that teaching, of course, is very important for that. Patient care, very important for that. But 1/3 of the component is research. So I'm happy to say that this times, this is the Government of India ranking. And JIPMER was ranked as number 4 in the medical category in India. And you can see this graph, it is slowly going up. So it is related to other services of the hospital also, but research is an important component. So, ladies and gentlemen, I can say that writing and publishing a scientific paper becomes enjoyable when you split it into simpler sections and approach each systematically. So I started like this. I started very late. Compared to my student, as I said, I was nowhere. I wrote my first case report at the end of my senior residency. I had become a specialist 3 years after that as a case report in Indian Journal of Surgery. But we persisted over a period of time with the strong backing of everybody, my mentor, my students, my residents, the atmosphere in the hospital and the center I am working, that today I have been given the responsibility to edit the same journal, which was my initiating journey in research as the first publication. And of course, with time, of course, now we have started a journal for Amasi. I'm happy to say that just 2 days back, the second issue has been launched. And again, I have the responsibility as editor-in-chief, and Dr. Kalayarasan is the editor for this journal. He's doing most of the work and I'm getting the credit. And this is JIPMER journal, almost 8-9 years. I'm editing it with all my colleagues, good colleagues, who are again propagating it forward. And this, of course, is at the international level. This is the Journal of Gastrointestinal Surgery. That's the official journal of SSAT. Unfortunately, very few that take from outside North American continent. I'm happy to say that they've included me as on the editorial board. And this is how you disseminate. You publish, others read your article, cite your article. That is what we call it as citation. This disseminates your work not only in a written form, but also in a research form where they include. So once you have got good experience, we thought that we should disseminate our knowledge through our writing also. And writing on writing, as I said, disseminates your experience and knowledge. As I said, the baton has to be passed. Unless and until you pass the baton, it will not help in capacity building. Capacity has to be built. The next generation has to be made ready. So I would like to conclude with the statement which is mentioned on a plaque at the Clinical Center of NIH. Research elevates teaching by introducing new knowledge and practices, which in turn improves the quality and standards of patient care. And the challenges and discoveries encountered in patient service then open up new avenues for further research. So it is like a cycle, complete cycle. So unless and until you initiate that, it will not lead to good practice, clinical practice. And unless and until you imbibe new innovations, new techniques in new practice, you will not know exactly what works, what does not work. So then in short, the key points, why should you publish? So I've already elaborated on everything. Advancement of medical knowledge, improve patient care and outcomes, cultivates the research of evidence-based practice, fosters innovation, professional recognition, critical mindset to students. This I feel is one of the most important things. And of course, leadership and institutional growth. So I would like to thank through this webinar my mentor, Professor Anand Krishnan, who has held my hand. As I said, when I joined JIPMER, I knew nothing about research. As I said, Dr. Kalayarasan mentioned ABCD, at least mentioned ABCD. I didn't know A also about research, but over a period of time, of course, you have to work hard, and bit by bit, sir taught me about it. And this is our team at the recently concluded Indian Association of Surgical Gastroenterology Conference at Chennai. Some of them are our present colleagues, past colleagues. Some of them are present students, past students. Just happy to see everybody doing so well in the field of surgical gastroenterology. So that's why again I'm telling, that's my one-line key message through this webinar, that better late than never. So once again, I would like to thank Dr. Baiju SENADHIPAN for giving this opportunity through this important, prestigious webinar and sharing some of her experience on publishing. And I will say that I cannot say that if you don't publish, you will perish, but still I will say it is better to publish so that you can, it is something very important for the advancement of a community of medicine. Thank you very much for your kind attention. Thank you very much.
Thank you, sir, for the wonderful lecture on publish or perish. Recently, actually, last slide was sir was showing. We had a debate in Indian Associate Surgical Gastroenterology recently concluded, and I had to debate against sir for not publishing. Actually, I accepted the invitation for debating against Vikram Kate sir with some resentment. I know that publication is needed. This thing was, if the publication should be done by the busy clinicians or not, or it should be done by a separate people who are keen on publications. That was the question raised by me. So what is your take on that, sir? And one
Yeah.
more thing, sir. It's all depending on the center which you are working. Probably Kalayarasan, being a busy practitioner, can publish the papers probably because of your mentorship and the center which he is staying. Am I not right, sir?
Actually, both the points I have mentioned in the lecture, that number one, that we are consumers of research. If we are consumers of research, it is the responsibility of everybody to contribute something to it. You may not contribute in a big manner, but you should contribute to it so that the people in future will utilize what we are contributing today. So that's the reason that everybody should contribute, because you may find something which nobody else have thought and found out. And unless and until you put it on the print of paper, how others will know? And regarding institutional setup, I already mentioned that fortunately I was in the institutional setup, but it can be done. There are many, many institutes in India as well as in the world which do not typically fit into an institutional setup, who have done voluminous research on all areas of practice, what they do. That is what I'm trying to say.
Yeah, Kalay, the floor is yours. You can regulate the floor.
Thank you, sir. I think actually when this topic was given, in fact, I had some doubts whether we'll have a good participation, and we're happy to see almost 300 plus 300 surgeons logging in, which itself shows the interest in the field of publication. I think before we start the discussion, I was just going through the chats. Some of them were asking about, we have nicely covered the part of the publication. And what about if we don't publish, are we going to perish? So what is on that aspect? I think before I ask Sir to respond to that, I'll just share my thoughts on that. Because Kadesa did mention about that aspect. I think in the current era, when there is information, we are all flooded with information, especially the patients. I think the only way, because this is a question which many students do ask about it. I'm not interested in working in an institute. I'm more interested in practice. So let me learn about the more of the surgical skills. I think publication is not something which is going to bring patients. But I think in the current era, when there is too much of information available to the patients, what becomes more reliable is the information published in standard journals. And probably I think surgeons should think it's also a way of projecting yourself, or say for what people in practice tell, marketing yourself. Even publications also a way of marketing yourself, because it, for the patients, I think when they see, okay, this surgeon has published in a journal, and when you cite your publications as the information to the patients, that becomes a much more reliable information to the patient than something which is available in the Google from non-indexed or publications not in the journals. I think that's to partly answer, if I don't publish, I'm going to perish. Maybe Katesa can add to that point.
No, that's the last point Dr. Kalayaраsan mentioned, that of course that nobody will perish. You can say that, but I feel that academically and research-wise, if a person is doing excellent clinical practice, or I'm repeatedly using the word clinical practice, this extends to all type of practice in medicine. The thing is that I personally feel that it will be a little bit of an injustice if we do not bring out something which we have learned over a period of time before we relinquish everything and retire. And something should be contributed towards research to carry it forward. So that is what is, I feel that it is not that the humanity, as Dr. Puneet Dar has mentioned, should perish, but the scientific community definitely will not perish, but definitely will bring it down if you have more people not contributing than people who are contributing. That is what I feel.
We entertain one-to-one interaction. I asked Dr. Daksh, who has raised his hand, to ask the question directly to sir.
Good evening, sir.
Good evening.
Sir, I am Daksh. I am pursuing first year MBBS. So I
Okay.
just wanted to ask, what will be the right time to start a research?
The right time to start is in first year. Now we have something called as you have summer students program by ICMR. That's there for a long time now. So there you can do the research right from the first year, second year. In JIPMER, we have a similar type of what we call it GJ Straws. So we start the program and the students can publish 2 or 3 papers within their MBBS span itself. That's what I said. I did it very late, but I have some students whom I have mentored, and they have got 3 papers. I did not put that particular slide because of want of time. We have MBBS students publishing a date of 500 consecutive peptic ulcer perforations in Australian New Zealand Journal of Surgery. So they collected data over a 2-year time. So they start in third year, and during the internship only we publish. So it can be done anytime. And as I said, you already have an opening on ICMR. It's called a short-term studentship program. It's already there.
And thank you for joining, Dr. Dash. Actually, these are the people who have to take the publications forward. Dr. Rajesh has raised his. Please go on.
Hello, Baiju. Can you hear me?
Yeah, Rajesh from UK.
Yeah, Rajesh from UK. And Baiju, nice meeting. I always attend your meetings because it is international level, and the discussions were all extremely good. And I also attended your debate because you are a keen publisher and you are a keen researcher, but you debated against research material, publish or perish. So I just want to add to this meeting, publish or perish is correct, because I worked in various hospitals, from smaller district general hospital to the highest level of university hospitals and everywhere. What I want to see is publish or perish your ideas. So you come across some cases, interesting patients or interesting concepts, which unless you publish it, it won't be known to the world authority or your colleagues or international faculty or medical students or anywhere else. So your ideas will perish if you don't publish it. So it is not you won't get perished, but your ideas definitely, that will go away. For example, now I am on call and I'm finishing my on call and coming home, and I tell my registrars, you will find a variety of interesting cases during your on call. And it will be variety, different concepts. And today I had a portal pyoemia, pneumobilia, and also a rare foreign body in the rectum, and all sorts of things. So if you don't publish these ideas or cases which you come across every day, and that ideas will perish, and that knowledge which you can impart to others will go away. So my take is, even if it is a small hospital or big hospital, whatever new ideas comes, please publish it into the local forum or a local journal or a local conference, or you just publish it. So this idea of publishing and research interest should be encouraged from the medical student days onwards. Now, for example, Vatikuti, me and I think Kalayarasan, we both are going to Miami to present our data on robotic surgery. So I encourage medical students to do a research, and they're also called international explorers, young explorers. They also involved in the research, and they come across and they get a notification that the Verticity Foundation will give free tickets to the conference, and so your research is published. So thank you for this wonderful time, and thank you for the discussions. And my take home is research should come from medical students. Continue to research and publish. Thank you. Thank you, Baiju.
Thank you, Rajesh. Kalay, you can take the question from the floor.
Yeah, I think so. There was a question on the plagiarism part, and so you want to touch
Yeah,
upon that.
what is the
Actually,
question? What is the
so the question is on plagiarism. Maybe actually it was from One Day Bar. Because the next part of the question is not clear. Use of guide prototype articles. So I'm not sure what he means.
Okay.
But probably I think we can cover something on the software
Yeah.
which
Yeah,
researchers.
I feel that as far as when we write a I'll tell what we usually do is when we write a manuscript, we have always told our students that once it is complete, before we plan submission to any journal, we have to utilize a software for which checks the plagiarism, the similarity, what we call it. Technically, the words plagiarism is not so good. The similarity index, and it gives you a good PDF file from which you can check. So good softwares are available. I'll not name any particular software. And then with that, you can assess whether the manuscript is fit to be sent. If you find the similarity level is high, similarity means what? Percentage as well as lines. While you are writing, sometimes it happens that 4 or 5 lines ditto, it comes from somewhere from where you have done the references. So those sort of things you have to modify and make sure that the plagiarism similarity index is less. There is no classical percentage for that, but in the range of, if it's an original article, 10-15% is acceptable. And those continuous lines should not be there. Once you find that, because any good journal, when you submit it, they will do this at their end. So it's always better that you do it at your end and make sure the manuscript does not get rejected based on high similarity index. That is what I can say. But I'm not familiar with the other aspect what is mentioned, prototype articles, but that's a very simple way it can be done.
We can,
Dr.
yeah, Dr. Ashwin can unmute and ask his question.
Hello, sir.
Yeah,
I am
hello.
from RCC Trivandrum Surgical Oncology.
Okay.
So most entry-level researchers would be starting off with case reports, but most of the major journals very rarely publish case reports. So, sir, you are the editor-in-chief of multiple big reputable journals. So what are the things that you would look for in a case report? Is it the uniqueness of the case, or is it the quality of the manuscript?
No, I will
terms of
tell you
language?
one very simple mechanism by which you can
Yes, sir.
find out what you have found out something rare is classified as a case report or not, because this question has been asked to me several times. I agree with you that although many journals would not take case reports, there are exclusive journals, first of all, which take only case reports. So you have a place to send the case reports because it's easy to write. Now, what do we write in a case report? 4-5 lines of introduction, your novelty, why do you say novel? Excellent pictures have to be there. Without pictures, no case report will be accepted because that's the documentation what you have found something rare. You cannot write about something. Anybody can write anything, but unless and it is documented by proper photographs, it will not get accepted. And the third thing is something I have found, let's say I have found something new. I am not very sure. The person will ask the mentor, the professor. Professor may say, yeah, this is very good and this is very rare. You publish it. You'll find it's getting rejected. The mistake what has happened is that when you find something like this, you put it in PubMed and see how it is getting published now, that rare thing. It is very unlikely you'll find something which has never been published. That is very rare. But if you find that right now, let's say there is some concept you have found, something very rare disease, some rare presentation you have found, that presentation is still coming as case reports right now in index journals. Still 1 case, 2 case. So it's rare. On the other hand, if you find what you are thinking rare, you find there's a 20 case series, then another 35 case series, 40 case series. Now, if you have existing 30 case series, 25 case series, who will take your 1 or 2 cases? So that's a very simple method. Anybody can do with the help of just internet and PubMed access. Is it okay, Dr. Ashwin?
Dr. Abhinav?
Anything more?
Yes, sir. Hello, sir. I'm Abhinav, third year student from Tirunelveli. So I
Hello,
would
Abhinav.
like to ask, like, how do we develop an interest for the particular topic to do a research on it? So, like, right now I got selected for ICMR STS, which you mentioned, but it's not really the topic which I am interested in.
My suggestion would be when we start doing the research, we cannot do focused research. And that's why I showed these things little later on. Okay, focused research can only be done once you have become a good researcher. Okay, so that is not possible in initial phase. You have to first start learning research. Learning research, it's like when you start learning surgery, you cannot start learning surgery by saying, I will only become a esophageal surgeon. Not possible. You have to first learn overall surgery, then a part of GI surgery. Then over that, you can go into esophageal surgery. Same way here, you have to take the pathway. So first, anything what you have to publish, any area. Sometimes when you are doing research with the help of your mentors, in general, they will give something which they are interested naturally. They know better. So you have to take that part, even if you are not very keen to do research on that area, then you can discuss with the mentor. But otherwise, it's always better to follow the mentor's advice because your advice is a little bit new at that stage and phase. So what you're selecting may not be appropriate, good for a, ultimately what is the end point of doing research? A good publication. So it may not be appropriate for a good publication.
Yes, sir. Thanks a lot.
Thank you, sir. I think there was another one of the common question which is also asked by one of the participants is in the era of AI, how to appropriately use AI without, getting into ethical issues of using AI.
Again, AI is also the same similarity. Now we have software which checks general similarity also and AI similarity also. So AI is definitely very complementary, but it should not be if it's like, when you want to give a speech somewhere, being in administration, little bit speeches I have to give for some inaugurations, etc. If you take a AI speech, you see the person might have that speech in the phone and they'll say, ditto he's saying from what you have got. So you have to take the speech, take the points and then modify it. The same technique can be used there. Utilize it for complementary purposes, take the positives from that, but you should always use your own ideas and then put it.
Dr. Puneet.
That is what I can get. Yeah.
That is in the chat box. Dr. Puneet, please unmute.
Hi. No, I think it's a fantastic and very well presented, Dr. Vikram. Always a favorite. I've forwarded to a lot of other groups. I hope they pick it up in the recording also. I think very, very important points made. I think the important thing is it's, when I have to look for what you said about evidence, when I have to look for actual evidence on a certain thing, I go to clinicaltrials.gov and see how many trials have actually been done on that. And I'm surprised to see the immense number which has been done, but very few published. And it worries me. So I published an article called, the evidence biased medicine, because if we let, Baiju's original question, why should busy clinicians do? It's, I think, their responsibility, because if we look at what has been done by some center which we don't even know the veracity of that can be verified or not. In India, every medical college has hundreds of thyroids being operated, but they follow guidelines set by somebody who's they've scientifically put it, which is probably good, may not even be relevant to India. So I think it's a responsibility to have that. And I find on clinicaltrials.gov, particularly for, say, the the pharma or some kind of sponsored research. I'll just give an example. Suppose we do 100 trials. The pharma company does 100 trials. 99 don't work. One works, and they publish that one. Just imagine what the problem with that is. So it's very important for all the other 99 also to publish, as Dr. Vikram so elegantly stressed, that do not think that negative research is not important. It's just as important as, because people tend to see one positive thing and everybody wants to do that without even realizing, applying all the other features which even that study does. So I think it's very, very important, the points he's made. I just want to re-emphasize all the issues that he actually said.
Thanks a lot.
Thank-
Thanks a lot, Puneet. Yeah, one line I would like to add here. I did not include the slides because I thought presentation should not become very long. When we look at randomized control, that's considered level 1 evidence if it is a good RCT. And as just now what Dr. Puneet said, 99 are not published, 1 is published. So the step further from this is basically the systematic review and meta-analysis. So when you do the meta-analysis, and let's say we have included 20 studies in the meta-analysis. Meta-analysis, why we call it meta-analysis? Because we do analysis after publication. So that is why it is called meta-analysis. We have the classical forest plot, which will give you the outcome for all the outcomes which are listed there. So when you do that, when you include the studies, one of the plots what I showed, it's called as funnel plot. So in the funnel plot itself, you can find out whether there is publication bias. That means only the positives are publishing and the negatives are not publishing. Once you know that, of course, in standard journals, once you know that it is there, then in those circumstances, we can easily actually refine and get out the clinical outcomes from a good, well-conducted meta-analysis. When I say good journals means, what I mean is when you have to interpret from a meta-analysis if it has got a wide variability. When you actually go into the forest plot and reading a forest plot, if you have a wide variability in the forest plot, that means all the articles which are included, they do not match with each other. Then also you cannot take a positive interpretation from that meta-analysis. So that's a little bit going further. But definitely these problems are there, that if you have some articles which are published only in favor and others are not published, it can lead to problems because everybody is not going to read meta-analysis, because interpreting forest plot is also difficult. So they might only straight away read a randomized control trial. So that's the point. I just wanted to expand on that.
Thank you, sir. I think there was another question related to the, I think sir has clearly mentioned. So journals do have the plagiarism checker also has a component called AI checker. So if you are taking everything with the help of AI, that will be easily detected. The proper way of using AI is you write on your own, and then probably you can use the assistance of AI to paraphrase it rather than getting the full information from AI, because that will be definitely detected by all the softwares. Dr. Prashant from Oman has asked, sir, you have published many RCTs. How do you address the question of ethics while recruiting controls?
See, the thing is, in most of the RCTs, the control is the standard of care. So there is nothing unethical about it. We are applying the same treatment, which is a standard of care, which we are giving. We are administering daily to the patients. Daily, absolutely. Like when we did the RCTs on IRAS, what we were doing right now for the patients, that was the control. So then nobody can object to that. And the intervention law, people can say that there can be an objection. So that is where we have the scientific committee and the ethics committee. They evaluate and they give clearance to the project at the protocol stage. That is what Dr. Puneet mentioned, that once you go to the registries, the CTRI is Indian and the clinical trials.gov is international registry, we find so many protocols submitted, but they don't complete the research. The reason for that is in between they can have problems. The ethical committees can object when you are doing the study because you have to send the reports, and they might stop the trials. So that is another reason for not publishing it in future. But what I would like to say is that there is no problem with the control group. The problem only comes with the interventional group, because those are the groups we are going to try something which has not been tried as a standard of care. So we explain it to the patient. Of course, the proper informed consent has to be taken, and then we proceed. Any randomized control trial has stopping rules, standard RCT. So if you find that there are some adverse effects, some problems are there, we stop in two conditions. One is if there is a problem, then we stop. Obviously, you have to stop. Number two is that if it is very good, the intervention, then also we stop. Like if you find laparoscopic surgery is proving very superior to open surgery, why you should actually complete the study with 200 patients in each arm and administer open surgery to the patients who are undergoing open surgery? Because we have found after interim analysis 7500 patients, we have to mention that in protocol that it is superior to that. I'm just giving an example. So then we stop the trial. So in those both the circumstances, trials are stopped. When we use the word randomized control trial, everybody who are a little bit new trainees, they should not understand it as it has got a control. That's why it's called randomized control trial. It is controlled. It is not randomized control trial. Controlled. That means the whole study is properly controlled. And that is what we do. But of course, we have inclusion criteria under which RCT is conducted. But now we go forward, which is called as pragmatic randomized control trial. Pragmatic randomized control trial means we practically do not have any exclusion criteria and do a RCT as if it is in the patient hospital setting. So that is the step. See, we first do observational studies, then we find everything is okay, then we go to RCT. If we find RCT is working under controlled conditions, then we make it uncontrolled. So when it is uncontrolled, that sort of RCT is called as a pragmatic trial. That's how we go step by step. I hope I'm.
Dr. Ramesh Rajan, PhD. College.
Good evening. Thanks, Baiju, for the
Good evening,
nice
Dr. Ramesh.
session.
Yeah.
Good evening, Kate sir. This is Ramesh Rajan.
Good evening. Good evening. Good evening.
Yeah, nice session.
Good to hear you. Yeah.
One of my questions is many of these high impact journals have a high publication fee. You would agree? So how do you go about it for centers or institutions which do not get financial support for that?
I partly
So some
disagree.
people tend to
I partly disagree with
other
what you
journals.
said. No, most of the high impact journals in the world right now come into the category of hybrid journals, including Indian Journal of Surgery. Indian Journal of Surgery has got a publication fee comes to close to $4,000 per article. That comes to roughly 3.5 to 4 lakh rupees. But it is a hybrid journal. So a person, once you have acceptance, the Springer will send a mail and they will ask you to choose subscription mode or open access mode. If you choose open access mode, then only you have to pay. Otherwise, free. This is happening for all journals in the world. If you go to Lancet, if you go to all top journals, everybody is in a hybrid mode. Very few of them are there which are exclusive. They have what you call APC, article processing charges. Those, if you can't pay, you have to avoid and go to something else.
So apart from that, if you don't opt for the open access thing, you mean to say that the charges, if you don't opt for the open access, the charges are reasonable. That's what you mean.
No, not reasonable. Zero.
Is
it's
it
called subscription mode?
Okay.
Zero. So you say, see, I'll just give a little expansion on this answer. See, somebody has to pay for that publication. So when you put open access, that means you pay. Let's say you have paid $3,000 for that article. It is open access. So anybody can download the article and read it free.
Yeah, it's free.
If it is the other way around, you have not paid as an author. A journal has to charge. So for every download, which is there for Indian Journal of Surgery also, for every download, they will charge. You have to pay that money and then only read the article. So they earn the money either way. It's like that. That's how it is.
Thank you.
New information. Dr. Jagannath, sir. Dr. Jagannath.
Good evening, sir.
Good
Dr.
evening.
Baiju, as usual, one of the best. I think this interactions are very fruitful and it's a knowledge sharing. I'm very happy to I've been listening from the beginning, and congratulations to Dr. Vikram sir also for.
No, don't congratulate me. It's Dr. Baiju who initiated this.
No, both. See,
and Dr. Kalayarasan, as I said, I'm more happy than myself for him.
In fact, all three of you, I want to congratulate.
Thank you.
See, just at the outset, many of the time when we write the article, some of the, the question asked, can you take one opinion from the reputed national, expert who is in that field, or some international expert who can make some corrections before you publish? Is it true for all articles, or it is a must to take an opinion? or what do you suggest on that, sir?
That may be a little difficult, because if you say that if everybody starts sending it to some few people who are very experienced in this field, it may be difficult for them to have a look at those manuscripts, because those people also get invited for lots of reviews for very good journals. So that there also you have to be selective. I'm just telling a little bit from my personal experience. Many times I have to refuse the review because there is no time. So it might be difficult to generate time for the other part. But I will give two solutions for that. One is that you should try to get it read by people in your closed circuit, okay, who have published. If somebody has published good number of articles, naturally the person will become experienced. It's like, if you want to learn surgery, a person is experienced and he is assisting you. That's a better method rather than you trying to do it own with all the difficulties facing and all that. It makes the training perfect. And the second thing is, one of the things what we advise is, if once the manuscript becomes reasonably good, send it to a good journal. So you will get the reviewer comments. All good journals will have good reviews. They will put the comments. That is good enough for you don't expect acceptance at all. Just have sent it so that there are some faculty members in my hospital, they use that technique. It's a good technique. But for that, the manuscript has to have a reasonable level. Otherwise, there will be desk rejection. Desk rejection means, like I am the editor-in-chief of intentional surgery, we reject it straight from the EIC office itself. It will not go to reviewers if the manuscript is not good. So that should not happen. For that, it has to have a reasonably good standard.
Okay. Thank you, sir. Sir, one more concern. Whenever we have got a lot of material and, come to some, preparation of the draft and about to send to the, the editor, most of the time there is a little, time gap, not able to complete in time. And even when we send to the editor and, we'll not get any reply. Probably it is a suboptimal, and the reviewer also 1, 2, 3 they review, but most of the time it will be
They
just
take time. That's what you're telling, no?
yeah, waiting time, plus the reviewer also mention 1 or 2 comments. So even you correct that reviewer comments and then send it back, most of the time it will not be published. I think this is, I have gone through this personally.
This depends actually. See, one of the other techniques, one of the other tips what I can give here is that you should see, if suppose there is a journal A where you are submitting. So in that journal A, you see the original articles where submission time and acceptance times is given there. Any articles given, submitted on this date, accepted on this date. That will give you a rough idea how long the journal takes for the whole process.
Okay.
See, give and take little bit plus minus will happen. Some reviewer might review in 10 days, some reviewer might take sometimes 3 weeks. But overall, if you look at some, let's say 10, 15 articles, you get an idea what is the time span. You see, I am on the editorial board of JOGS, Journal of Gastrointestinal Surgery. So they send me, my job is actually to review. So every month 1 or 2 I get, but the time limit is 14 days. I have to review, otherwise I'll get reminders. So I also feel bad, and they are very strict about it. So it happens like that. So there you'll find the acceptance time will be very less. Some journals, 3, 4 months also they give leverage time to the reviewers. Then naturally the acceptance time is more. So this can be seen in the published journal itself. That journal itself, published articles.
Thank you so much.
Then you have to select.
Thank you. Thank you. Yeah. Good. Well answered, sir. Thank you.
Thank you, Dr. Jagannath. Sir Kalay?
There was a question on how important is the impact factor of the journal you choose for publication.
There are again lots of debates on that you should not give importance to impact factor. I agree that some journals, the impact factor may not truly reflect, but one of the things what we have seen from past experiences, one of the things I'll tell my colleagues or students is, you please check the volume number of the journal. So when you check the volume number of the journal, it tells how long the journal is in existence. So volume means usually in a year, it is a single volume, or sometimes in a year, you might have 2 volumes, not more than that. So if you see Lancet, okay, it will have volume as 250, 250 years it is getting published. Lancet is around 200 years old journal, more than that. So So you get an idea. So if the journal is published for 20, 30 years and all that, in general, it's a good journal. And then you go forward into that, what you have to do. So that is one of the very good ways of finding out. But if you find a 3-year-old journal and it's got an impact factor of 6, then it's a problem. No? 3 years, how it has achieved that. Then you should be a little selective and you should be a little skeptical that you may not accept that. Otherwise, it's very difficult to find out that sort of thing.
The other aspect is, I think maybe you can also share from your personal experience of reviewing manuscripts. So what advantage you get when you review the manuscripts?
The advantage is that first I'll tell how you get the reviewing invite. Reviewing invite usually comes to the corresponding author. So as you become little senior in the publishing field, you get the title, or I can say the place of corresponding author, and whichever publications you have published, there your ID will be mentioned down. Nowadays, many other IDs of co-authors also mentioned, but some of the journals only the corresponding author ID is mentioned. That's how you get the invite. Now, if you review it, the biggest advantage what I feel of reviewing is actually enhancing your own research experience knowledge. Because when you review for good journals, you see exactly the most problematic area. Now, actually, Dr. Biju had given me the thing on publish or perish, but most of the talks I have given is how to write a paper. So in that, I always tell that when you are writing a paper, when you are, this thing is there, when you are writing a manuscript, it is extremely important. I just little bit sidetracked. What was the question? You just tell me, Kala, again.
Yeah, the advantage of reviewing.
Advantage of reviewing, yeah. So those methodologies what we write, if you see some of our things have got accepted in presidential binary, those methodologies we pick up when you are reviewing from that articles. See how detailed they have mentioned. What are the points they have mentioned? Because the methods area is the most important in a journal. That gets targeted by reviewers always. If your methods is perfect, I don't think any manuscript will get rejected. The most problematic thing is the methods. It has to be absolutely perfect. Absolutely means absolutely. That you gain from the reviewing. And of course, when you review, then you get known in the field and etc. etc. That is a secondary, but it enhances. It's not only enhancing then when I was a member of ethics committee, when I was a member of JIPMER scientific committee, the central scientific committee. It was not only for evaluating the papers or the presentations, but most important thing is learning the points. You know that some person has done, oh, that's a beautiful point in research, what is done, beautiful point in methodology. You pick it up and then use it in your research. That is what I feel is the biggest advantage of reviewing.
Yes.
And of course, you do service to the scientific committee. It definitely does service because it's nobody gives money for reviewing. You take out your time. Well, thank you. Some journals give a certificate. That's what is that.
And also some journals do give access to their.
Yeah, that is there. Correct.
Like
yeah, Scopus and other things and all that. That also they give. Absolutely. That is an advantage.
I think the
others are some discussions happening in the chat box.
Yes, but most of the questions we have covered.
Yeah.
Okay, somebody is asking about some propensity score or something like that. I saw one of the chats. I don't know. But if it is answered, it's okay. That's fine.
But these are just come regarding propensity match studies. Wondering there are some tools to when you have to do a propensity match analysis. So studies on that. Are there any tools that can assist?
One message I would like to give again, one line message. I tell everybody who's working with me, don't go into areas where you have assistance from your faculty colleagues. Right from sample size calculation, if everybody will ask me, I don't know how to do it. It is not important to know how to do the sample size calculation. It's important to know as a clinician, what should be the primary outcome you're targeting that the person who's a statistician cannot tell you. And then the sample, the type of patients you get. So that sort of input you have to give. So you have to discuss it with the people. One line I'll tell about PSM analysis, that is propensity score matching. In propensity score matching, you do the analysis of observational studies and make the make the parameters match almost like a randomized control trial. So you get the outcome like a randomized control trial from observational studies. So this has come for the last 1.5 decade. That's fantastic that you can get, because in conventional observational studies, you may have a lot of confounding factors. They are actually removed when you do PSM analysis. So take the help of a proper statistician, or in our hospital, like we have from people from the Department of Community Medicine, PSM, they are experts in that. They use softwares and they'll give you. Same thing for meta-analysis. You don't have to do meta-analysis. There'll be somebody who will do meta-analysis for you. You are a clinician. Concentrate on what you require it from the clinical side. And the fundamentals, you should know what is PSM analysis. And that is what I would like to advise.
There's a question, which is a follow-up question. When you mentioned about the methodology as the most important part of the study, I think there was a clarification whether what you actually mean by methodology, is it related to statistics or how you do this?
No. Methodology means, as you know, Kalayaran, you can also answer that.
Yes.
You know very well that methodology means how the study has been done. 2-3 examples I will give. You have to put lots of references. So as I said, when I give the other talk, I usually show what it means by methodology. If you 10 to 15 references, we put in methods. Why we put a reference? Because if you are saying that I have measured A versus B this way, if I have measured A versus B this way, that should be a standard method published in world literature in a standard journal. Otherwise, reviewer will target to that. Reviewer will say this is not the way it should be done. If you say it's not the way it should be done, you cannot do it. You cannot redo it. You have done the study for last 3 years. After this, like suppose just to give example of H. pylori study, they tell this is not the way H. pylori should be tested. If they say like that, then what will you, how will you go forward with results and all? They'll say you are wrongly tested. People who are negative might be positive and people who are positive might be negative. So you cannot go forward. So that is what I mean by targeting the methodology. Sample size calculation, statistics is a small part of it, which statistical tests you have used. But the actual methodology, the procedures that you have followed to do the study has to be absolutely pakka. And the way you can do it is you see what are the published procedures from a good journal. That is what you have to copy it to. That's why they will even write if you are using a drug, from where the drug was manufactured, which company, if they are using endoscope, what type, all details are always given in good methodology, so that anybody can replicate the study in an identical manner. That's why we have so many publications in ERAS, because we have got almost now 8, 9, 10 publications, because the methodology keeps on refining with each publication. So now we know exactly how to do the study. And when we are doing it, it follows the pattern, so the reviewers can't find any fault into it. When they can't find any fault, they gave it a very high rating. And that's why it got selected into the presidential plenary. It's mandatory for DW that when it gets selected in plenary, you have to submit to Jai Journal. That's why most of our articles have got published in journals. It's like,
yeah,
that is what I mean by
yes.
methodology. I hope I'm clear. Yeah.
Yes, because when you, for example, you get comments from the reviewers, you can modify the analysis, you can modify the discussion part, but methodology is something which you cannot change. Once it is done, it's done. So that's why when you are designing the study, you should focus on that, because that you cannot change. If article is getting rejected because of poor methodology, it's very difficult to get it published also.
So that is why at the protocol stage, what Dr. Kalayarasan is mentioning, you should be alert at the protocol stage. Protocol stage means when you are going to start the study. If that time the methodology is faulty, what can you do 3 years later? It's like that.
Yeah, there's one final question probably on any guidelines of reviewing. When you review an article, any guidelines for that?
No firm guidelines. As I said, it is like an operation. You see, there's no guideline to do a particular operation. With experience, you learn. It's like that. Over a period, the general guidelines are there. Like in reviewers, they should know how to look at the introduction, what to look in the methodology, what to look in the results, and what to look into the discussion. As I said, as you have just now, Dr. Kalayarasan mentioned, discussion, anybody can change it. I mean, refine it. Introduction, there's nothing. You can always refine it. Table, they will say, put this table, add the table, subtract, make figure. Not very difficult. Methodology only, you can't redo it. It is an irreversible phenomenon. So you have to check it. But for reviewing, usually we target it like that. The most important section is methods. Then we go on to the others and then we find out if there are some suggestions. See, the aim of reviewer is not to target and shoot the manuscript. The aim of the reviewer is always to improvise on the manuscript. So as far as possible, you should always accept the comments, make the changes. Even sometimes they'll suggest to change the title of the manuscript. That also should be changed because they're experts. They're giving you good advice. And when your publication comes out in the journal, you will only benefit from the citations and the wider visibility of the publication. So that antagonism should never be there towards the reviewer. So when you're writing the comments also, I jokingly say always to everybody that reviewer is God. So never ever antagonize the reviewer. It's like that.
Yeah. Even I think some of the standard journals, when you are actually going to submit your review report, there are some predefined questions are there, and it will ask you whether is the study meeting those criteria. So that to some extent will guide you. But as I mentioned, it's, I think you, from your experience, you will know
Yeah.
which part of the study you need to focus. Like methodology is one which you really focus on that. Probably, I think we have answered, sir, most of all the questions.
Fine.
Maybe
So,
to Dr. Beju, sir.
yeah, it's time to wind up. There are many questions coming in, but if there are more questions, you can write in the WhatsApp group. I will convey that questions to Vikram sir, and he will be only happy to answer all the questions. I will be conveying to you if at all any further questions are there. And it's time to wind up. Before that, I invite you all for the SPB and GA Cancer Service Summit second edition, which is going to happen on 9th and 10th of May 2026. It will be happening in Kochi. It will be hosted by Dr. H. Ramesh. So we are sorting out the venue and website and all. So you can expect some flyers in the recent future. And we had a wonderful lecture from Vikram Carter sir. It was a mind-blowing lecture and it was thought-provoking also. When I thought of taking this subject as this, there was no other person other than Vikram Carter sir for this subject, and he had done the job very well. And about Kalayarasan also, no other person I would expect to moderate better than this Dr. Kalayarasan. Thank both of you for joining the forum. Thanks from SENADHIPAN Education Foundation. And thank Dr. Nambiar for introducing the moderator and speaker. I thank all the participants who have joined from all the parts of the world for your wonderful participation. And the next webinar is going to happen on 16th of November on MRI in rectal cancer. So stay tuned. Thank you. Good night.
Thanks a lot, Dr. Beju, for the opportunity. Thank you, Kalayarasan, for moderating it. And I'd like to thank all the people who have joined. And I think this is one of the first times I've done some international webinars also. This number I have not seen. I don't know. You really have a very, very wide reach. Systematic information percolation. That is what I said, percolation. That is very important. As I said, to have 250, 300 people online. People look at the webinar later on, but online, really great. Absolutely great.
Coming as a cross section means there will be people who is logging in and going out also. If you look into the entire number of people, it will be almost 3 times the number which you are seeing here.
Oh, okay, yeah.
Correct. 1,000 people might have joined.
Thank you. Thanks a lot. Thank you very much. Namaskar. Good night to everybody.